Welcome to our presentations for Immunology workshop. We are Group 9 and today we will be presenting a case involving Jack, a trauma patient who later developed complications following a blood transfusion. Our objective is to understand how the reaction occurred, what clinical findings led to its diagnosis, and most importantly, how such situations should be managed and prevented. Jack was admitted following a road accident and was transfused AB or H positive blood according to his blood group card. However, about 1 hour after the transfusion, he unexpectedly developed hypotension and breathing difficulty. Both are red flag features of an acute transfusion reaction. At this point, several hypotheses should be considered, including acute hemolytic transfusion reaction, TRALI, anaphylactic shock, and febrile reactions. Subsequent lab findings later revealed his blood group to be B or H positive, and further interview uncovered a significant detail: a bone marrow transplant 6 months ago. This becomes the key factor in explaining his transfusion mismatch and the reaction that followed.
Now let's examine how the blood group inheritance is affected by the genes, particularly in transplant scenarios. Before the transplantation, the genotype was AB, which resulted in as a universal recipient and compatible with A, B, AB, and O. But after the transplantation, the genotype started to move to B blood groups and it restricted A and AB and only compatible to B and O only. The ABO gene located on the chromosome 9 governs the blood group inheritance through codominance gene, while the RHT gene on the chromosome 1 determines the RH status via a dominant inheritance. Together, these genes regulate the antigen expression and also which is critical and crucial for transfusion capability.
In this case, the key immunological issue was that a bone marrow transplant fully replaces Jack's immune response with donor-derived cells. The donor stem cells produce new red and white blood cells, as well as plasma cells that generate antibodies according to the donor's blood type, not Jack's original type. During the early post-transplant period, mixed chimerism may occur, but antibody profile is still dominated by the donor. This means the blood group information from before the transplant may no longer be accurate. If the transfused blood carries antigens that react with donor-derived antibodies, an innate immune response occurs. The complement system activates first, forming the membrane attack complex that lyses the incompatible red blood cells. Innate cells like macrophages and neutrophils are then rapidly recruited. They clear the damaged red blood cells and release cytokines including IL-1, IL-6, and TNF-alpha. These cytokines drive fever, hypertension, and respiratory difficulty by causing widespread inflammation and capillary leak. Together, complement activation and cytokine-driven innate immunity explains the acute hemolytic transfusion reaction.
Once Jack received ABRH positive blood, his adaptive immune system rapidly launched a specific attack against the A antigen on the transfused red blood cells. The T cells were activated first. The helper T cells, CD4+, released cytokines and further activated B cells and macrophages. For killer T cells, CD8+, it destroyed infected or abnormal cells and act as antibody-mediated attack. For B cells, it produced antibodies such as IgM, bind quickly and strongly, and recognize A antigen as foreign. It activated the classical complement pathway and leading intravascular hemolysis. The hemolysis will release free hemoglobin, causing stress on kidneys and contributing to shock and hypertension. In addition, the complement fragments such as C3A and C35 triggers a cytokine surge. As the outcome, unmatchable red blood cells were destroyed and removed. The immune response will gradually wind down. However, Jack's immune system will retain memory B cells and T cells based on his donor's immune identity and strongly reactive to A antigen in future.
This slide explains the pathology behind the patient's condition, which is most consistent with an acute hemolytic transfusion reaction caused by an ABO mismatch. In this situation, the patient's A antibodies recognize and binds to A antigens on the donor red blood cells. This immediately activates the complement system, leading to a rapid intravascular hemolysis. As the red cells break apart, they release free hemoglobin, potassium, LDH, and inflammatory cytokines, which contribute early symptoms like hypotension, dysphonia, fever, chills, and flushing. The hemoglobin released into the bloodstream travels to the kidney, where it can cause hemoglobinuria and tubular obstruction, eventually leading to acute kidney injury. At the same time, the reaction triggers coagulation cascade, increasing the risk of DIC, microthrombi formation, and multi-organ failure in severe cases. Overall, this reaction results from ABO incompatibility and leads to widespread hemolysis, renal injury, and systemic inflammatory complications.
Once symptoms appear, the immediate response should be maintaining IV access with normal saline and continue monitoring his vital signs. Urgent investigations must then follow, including repeat ABO RH typing, DAT, hemolysis markers, and urinalysis, alongside supportive care such as oxygen therapy and intravenous fluid. To prevent similar accidents, mandatory retyping and cross-match should be performed, especially in post-bone marrow transplant patients. Clear documentation, pre-transfusion verification protocols, and proper patient education are crucial in ensuring transfusion safety.
All in all, Jack's post-bone marrow transplant states that his current genetic and blood identity, B+, now opposes the donor's AB+ blood type. The donor-derived stem cells and lymphocytes reconstituted his immune system, producing antibodies consistent with the donor's ABO profile, being anti-A antibodies. Transfusion of AB+ blood matched his old blood group, triggered an immunological incompatibility, leading to complement-mediated intravascular hemolysis. This then explains his rapid hypertension and respiratory distress. Overall, a genetic shift in blood group expression, immunological mismatch, and the resulting pathological hemolytic reaction account for the adverse events.